Hi guys, so this is part 2 and we're going to be talking about Prince Dakar. First of all, I want to apologize if you hear the snoring dog. It's a little Shih Tzu and it's too cold to let her outside. So we see that Prince Dakar is admitted with weakness, dizziness, and he has some psychosis. His prior history includes recent asthma exacerbation treated with albuterol and prednisone. So our clue there is prednisone. So we look at Prince Dakar, and he's alert and oriented ×4. He's got multiple ecchymosis, which is bruising. His abdomen is soft, and he has bowel sounds. And he has lower extremities that are really thin, and he has a trace ankle and pedal edema. So what other assessments do we want? Well, with Prince Dakar, he's got prednisone, so that we're thinking that he has a Cushing-like syndrome. So with Cushing's, we see these skinny, bird-like extremities with this big round trunk, or truncal obesity. He's also going to have a moon face. And if you look at his picture, he does. He has that rounded-looking face with the big, heavy jowls. He's also going to have some, what we call a buffalo hump. He's going to have poor wound healing. He's going to have risk of osteoporosis, especially if he's on it for long term. So his problem is he's got too much prednisone or corticosteroids, and it's causing Cushing's. So when we look at Prince Dakar's labs, we're going to see that he's hypernatremic and hypokalemic. We also see that his calcium is really low. So this is why we would see osteoporosis, because the glucocorticoids are causing the calcium to be excreted, and so it's pulling the calcium out of the bones. So what would we anticipate from our healthcare provider? We would expect to see, first of all, a urine for some glucocorticoids. We would anticipate a diet change. He's going to be on a low sodium, high potassium diet. No, we need to know what foods are high in potassium, so we need to teach him about that. We also, the healthcare provider will probably decrease his dose of prednisone, maybe put him on an oral, put him on an inhaled corticosteroid. Some of our nursing interventions, we want to keep him safe. So we're going to be ambulating him with assistance. He's going to be a fall risk because these guys can break their hip and fall. We're going to be putting him on seizure precautions. He's going to be on a cardiac monitor. We're going to be assessing his skin, because these guys have very, very thin skin, and so it tears very easily. He's going to be on an oral glucocorticoid, so we're going to be assessing for, we're going to be teaching him about his oral glucocorticoid. If he were to have an adrenalectomy, he's going to have a lot of circulating hormone, and so he's going to need to be taught what to look for before he reaches a hypoglucocorticoid state, also known as Addison's disease or adrenal insufficiency. Okay, next patient is going to be Ann Bonney. She is admitted for an irregular heartbeat. We can see that her heart rate's up, her respiratory rate's up, her blood pressure's up. She's 5'9" and she weighs 110 pounds. That's kind of thin for someone that tall. And what else do we want to know? So some things that we would want to be assessing, again, is looking at her lab values. Her TSH, so that pituitary that signals the thyroid to work, is really, really low. But her T4, which is the thyroid hormone itself, is really, really high. So we're going to see, what we're seeing here is a hyperthyroidism. So what do we do for hyperthyroidism? Some of our nursing diagnoses would be impaired nutrition, less than body requirements. So we would want some high food or some high protein foods that are, we would want 6 meals a day. We would expect from our healthcare provider either some antithyroid hormones, methimazole and propylthiouracil, which is going to help, which is going to block the production of thyroid hormone. We also would anticipate a beta blocker, because we know, again, that the thyroid works on our metabolism, and so with that really high heart rate, it's going to help bring it down. The healthcare provider may order some radioactive iodine to kill part of the thyroid, or she may need some surgery. So, once her thyroid is under control, then Anne's going to have a thyroidectomy. So the thyroid, you can see here, we have our thyroid, we have the trachea, we have the recurrent laryngeal nerve. So the first thing we're concerned about is that that's a lot. When they do surgery, they have a lot of swelling, right? So we would want to make sure that her airway is clear. So some post-operative interventions, and we'll talk, we're going to put her in a 45-degree, put her up 45 degrees. To make sure that we don't have all this swelling, especially around the trachea. We also want to be talking to her because you can see our recurrent laryngeal nerve. If that puppy is cut, then the patient's not going to be able to speak. We're also going to be concerned about, because our parathyroids are they're like the size of a head of a pin, and they sit right behind the thyroid. So we're going to be assessing her calcium to make sure that the parathyroids haven't been obstructed or removed. So we want her at a 45-degree angle. We want to be assessing her speech. We want to look behind her neck to make sure that there's no bleeding. We want to be assessing her speech. We want to be assessing her breathing. We want to be looking for signs and symptoms of hypocalcemia, which would include numbness and tingling of the mouth. We would anticipate maybe some laryngeal stridor, God forbid, because that's the last sign. She may also complain of some muscle cramping or what we call tetany. She's going to need calcium gluconate at the bedside. She's also going to need a tracheostomy tray, because if we get too much swelling, it's going to occlude the trachea. Now, people say, well, why can't you put a tube down her throat? Well, if her trachea is occluded, how are you going to get that tube down there? So she needs a tracheostomy tray at the bedside, so in case she starts having some difficulty breathing, we're going to be able to have someone insert it for us. So he reports that due to the extensive overgrowth of thyroid tissue, he was forced to remove the parathyroids. Again, what would be some of our nursing assessments? Assessing for hypocalcemia. So Chavostics, Trousseau's, numbness and tingling around the circumaural numbness and tingling, laryngeal stridor. What would be some of our nursing interventions? I would like to keep the calcium gluconate at the bedside. We call that nursing voodoo. If you have calcium gluconate at the bedside, you're never going to need it. But the minute you don't have it, guess what? We would anticipate the patient's going to have to go home on calcium supplements. So we're going to need to teach about calcium supplementation. They need to take it with food because that increases the absorption of calcium. They also need to eat foods high in calcium. We know that a lot of our dairy products are high in calcium. We would also, let's see, we would teach about calcium, that it's constipating. They need to increase their fiber. They need to take it with food. And on discharge, she's going to have a wound across her neck, so she's going to need to know all about the post-operative care. Okay, so William Blythe. William Blythe was admitted to the medical floor with seizures. He has lung cancer, opioid therapy, and chemotherapy. We can see that he is a tall gentleman with, he weighs 195 pounds. So when we look at William Blythe's labs, he's got a sodium of 109, a potassium of 3.9. Looking at his serum osmolality, he is really, really low. Normal is 275 to 295 or 280 to 295. So looking at this, we can see that he's saving all of his water. His urine osmolality is really high. So again, we can see that he's saving all of his water. So some of our concerns, this gentleman has what we know as syndrome of inappropriate antidiuretic hormone, which to me is a misnomer because the antidiuretic hormone is like a double negative. Anyways, what I'm saying is with him saving all of his water, he's not excreting it. He's got too much of an antidiuretic hormone. Are we going to be seeing any edema? No, it's all in the core. So he's going to be hypertensive. He's going to have a low urine output. We would want daily weights. We would want eyes and O's. We can see that the healthcare provider has ordered some 3% saline. What's our concern about that? 3% saline is a hypertonic solution. So if I'm giving a hypertonic solution, I want to be very, very meticulous in listening to my lung sounds to make sure that my patient does not go into fluid overload because I'm trying to pull that water out. So some of our nursing diagnoses, we have a fluid volume excess, so we would do daily weights, eyes and O's. He's going to need some teaching on a high sodium diet because he really this may be chronic. Because we know that when it comes to lung cancer, our tumors can actually secrete antidiuretic hormone. We also have electrolyte imbalance. He's going to need seizure precautions. He's going to need to be close to the nurse's station. He's going to need some of our discharge teaching. We would want the head of the bed elevated, so he's going to need to elevate the head of his bed at home. That will, or no, not elevate. We want it low. I'm sorry. I'm thinking of something else. So we want his bed low to help trick the pituitary into not secreting so much.